Next, Dr. Stratonese will share with us monoclonal antibodies in the treatment of orbital inflammation.
Thank you, Richard, for including me in this symposium. It's an honor and pleasure to stay here and have the opportunity to present. So I would like to just to have a taste of the audience about the knowledge of the monoclonal antibody and their use in the inflammation of the orbit. So the use of rituximab in orbital inflammation when is indicated in moderate severity AID or is indicated for compressive optic neuropathy, is first-line treatment of IOI, is first-line treatment of even thyroid eye disease, is chimeric monoclonal antibody which targets CD34. Which one is the answer? Second is which one of the following is true for tocilizumab, is effective in mild thyroid eye disease, is suitable treatment for option in corticosteroid-resistant thyroid eye disease, is an anti-TNF monoclonal antibody, is effective in reducing the exophthalmos, is administered orally. And this is the third question. Is atipramab a suitable treatment for option for compressive optic neuropathy? Is atipramab effective in mild thyroid eye disease? Is effective for treatment of lead retraction? Has comparatively better efficacy than steroids in reducing disease activity? Or you think that atipramab is effective in reducing proptosis? So we will get to the polling after okay, and see if they match with the, I would just make sure if I have to give the presentation or not. So the no financial disclosure. Before I start to talk about monoclonal antibody in orbital inflammation, allow me to remind that orbital inflammation is not a diagnosis. It's not a diagnosis. It's a response of the immune system. And the causes can be many. And so before that we think to use a monoclonal antibody in orbital inflammation, you have to make sure to know the diagnosis and which is the cause. Because if you have bear in mind that the monoclonal antibodies is a very strong weapon. As all the strong weapons, they have side effects. So if we use monoclonal antibodies in orbital inflammation that's hiding an infection of neoplasm, it would be a disaster. So that is very important. So the area where we can use the monoclonal antibodies are the autoimmune disease or the autoimmune-like disease. We define many diseases that we still don't know exactly the mechanism, but we classify as specific the disease that we have criteria to define the diagnosis. And we normally call no specific the ones that we make diagnosis using exclusion criteria. Although you see here that I included also the GG4-related disease, for which actually we have criteria to define the disease, although there is still under discussion and the level, especially regarding the level of the IgG4 in the test blood, if it's useful or not for thyroid. And so I leave that, although it's overlapping the two categories. So the basics of the autoimmune disease, it's when the body is unable to differentiate the self and non-self antigen, and this results in overreaction and response against the tissue. So we have some diseases that are organ-specific, where the antigen is related to the specific organ, and we have not organ-specific disease, autoimmune disease, when the antigen is diffused everywhere. It's not related to one single area, anatomical area. So the immunosuppressive drugs in generally are drugs that, molecules that can interfere with any of the steps of the immune cascade. And we have not specific immunosuppressant and specific immunosuppressants. The not specific, generally, they just block the transcription of the DNA, of the RNA, and so generally they lower the proliferation of the B and T cell. And so the kind of the immunosuppression is wide and is not specific, not targeting a specific site. On the other hand, the specific immunosuppressant, and the ones that we are talking in this presentation, are the ones that have a specific antigen and as a target. And in theory, the more we know the pathogenesis of the disease, the more we can use and the better we can use those medications, those drugs to manage any autoimmune disease. So the strategies that they normally use are the B-cell depletion, so targeting a specific antigen receptor on the surface, or we have the other medication that can regulate the T-cell activity, and they can inhibit the signaling of the cells and or inhibit the small molecular that serves to intercellular transmission, or inhibit the monoclonal antibodies and block the cascade of the complements. So as you see here, we have many targets, and unfortunately, we are using these monoclonal antibodies on the basis more often just empirical. So we use considering some mechanism that we know of the autoimmune disease, but we don't know exactly. There are very few disease that we know many, a high percentage of the mechanism. So we select the monoclonal antibody on the basis of the pathogenesis of the disease. But the huge report, there are growing literature that in the last 5 years that is really, literally booming. But most of the reports are just using empirically with no exactly knowledge about the mechanism of the disease they are treating on. So rituximab is one of the most used. It's more than 20 years that was introduced in use in medicine in general, and specific even in our field in oculoplastic. It's very familiar for the oculoplastic and orbital experts, and is a monoclonal antibody that targets the CD20, resulting in depletion of the B cell, and this is the area where the rituximab works. So I think most of you in the audience, they know already that there is a controversy in the use of the rituximab in Graves' disease. There are two main studies, one conducted in Europe and the other one in the United States, that are absolutely conflicting results. In Europe, I don't think it's geographical variation, but it's in Europe, in Italy specifically, rituximab seems to be quite effective in reducing the and in treating for treatment of Graves' disease, and on the other end, the study in the United States was not. I would like to draw your attention on this. That's in Italian study, we used the rituximab quite early, and as you see, there was 4.5 months from the onset of the disease, in contrast to the US study that have been using the rituximab after about 30 months. Which means that probably rituximab is useful as alternative to the steroids, instead as using as medication for steroid-resistant patients. There's last year a meta-analysis that was published on rituximab showing that there are 11 studies that might be considered with 167 patients, and seems that rituximab is pretty effective in thyroid eye disease, although there is not robust data which can support the use of rituximab routinely in thyroid eye disease. And beside that, we should also discuss that some patient, couple of patients treated with rituximab has been reported that they have a very severe side effect just after the infusion. They had decrease of vision, acute decrease of vision due to the compressive optic neuropathy. And as I reported in this review, it's probably due to the expansion of the orbital volume due to the massive lysis of the B cell. So you should be aware that in patients with threatening of vision, severe thyroid eye disease probably should be avoided, instead to be suggested the use of rituximab. Rituximab is also well used in IgG4-related disease in 52 patients. Unfortunately, there is no control study. However, it seems that is quite useful in corticosteroid sparing effect. It's also been used in xanthogranuloma, but there are very few cases reported. Tocilizumab has become pretty famous, and I will tell you why later on in the recent years in thyroid eye disease. And this is the area of action of tocilizumab. It's an anti-TNF, it's an anti-IL-6 receptor. And the authors were able to, this is a very well conducted study, multicentric study. The author showed that in active corticosteroid resistant thyroid patients, tocilizumab is pretty effective in reducing the TSI and the clinical activity score. They also found somehow that there is some kind of reduction of proptosis. There is also improvement in ocular motility, and there are minimal side effects, no severe. Adalimumab was also used in a group of the UCLA. They reported 10 patients, and this anti-TNF alpha monoclonal antibody. They found that the reduction of the clinical activity score, but one patient developed a severe infection and represent 10%. And beside that, there was a report that adalimumab was used for other reason in one patient who developed, because of the adalimumab, the orbital sarcoid-like granulomatosis in the orbit. So he developed an orbital disease because of the use of this medication. Infliximab is also widely used in our field, and is another TNF blocker, and this is the area of action of infliximab. Interesting is probably quite effective in sight-threatening thyroid eye disease. And this is also our experience that I reported in this paper on 3 patients. These patients who had double course of steroids, double decompression, radiotherapy, and he had, as you see, severe worsening of the vision. So then we given to him a course of infliximab, and he had a pretty, acceptable response. Of course, some can argue, I don't know how much infliximab was part of this improvement, because he had, if you make the sum of all the treatments that who had, probably altogether they work for the final result. Infliximab is also used for the EGG4-related orbital disease. There are some reports that is quite effective as idiopathic orbital inflammation resistant to other immunosuppressant therapy. Then finally, let's have a look to the TPRO. That looks as the star of this day. TPRO inhibits the insulin-like growth factor 1. So in this view, in this light, it blocks from the beginning the cascade of the autoimmune, because it's probably the IGF-1 together with the TSH receptor are the onset where all the thyroid eye disease probably starts. So, and together, it's probably also block the activation of the fibroblasts and the accumulation of hyaluronic acid. I think most of you know the study that showing that TPRO is absolutely more effective than placebo. And interesting, compared to the other medication that we have seen so far, it's also improved the proptosis. It's quite remarkable, actually, the improvement of the proptosis. And we heard that also from Dr. Douglas during ASAPRS, that also in phase 3 they probably confirmed these results. So the bottom line is that the use of the monoclonal antibodies in thyroid eye disease can be reasonable if the TPRO confirmed all these effects that has been shown so far with no severe side effect, probably can be considered one of the first-line treatment in the future, although we have to consider the cost. And tocilizumab is very useful for resistant patients, and infliximab probably might be considered when you have severe patients not resistant to many medications, including also surgery for decompression. You can use rituximab in EGG4, and in resistant patients you can consider again infliximab. One of the suggestions that I would like to share with you, that if you really literally look at the literature, the number of papers that have been publishing on autoimmune disease treated with this new medication, it's literally uncontrolled. So if you want to have an idea, it's very difficult. So I suggest when you have the certain diagnosis that is one of those diseases, to work with rheumatologists and immunologists to handle those patients. So basically, although the introduction of the monoclonal antibodies is a revolution in medicine, unfortunately make our life a little bit more difficult, because we have now more complicated decisions to take, and believe me, it's very difficult to be updated considering all the study. And also the study sometimes has small series and anecdotal report. Also, it's interesting, besides that, as Dr. Rubin raised up 10 years ago, that the cost of these molecules is sometimes 10 or 20 times the traditional immunosuppressive drugs. So coming back to the question of this session, if the biological agent in some way can stop or can reduce our work as orbital surgeon, I would say that so far there is not enough evidence that they might reduce our work in the future. But honestly, if I have to give an answer, I would say that it's only a matter of time, and probably we will see at least some kind of reduction of the needs of decompression. We will see. Thank you.
Thank you very much.